I'm going to switch to English because I know there's translation. And certainly speaking now about science and new guidelines is a hard act to follow, the situation that we're all feeling and facing. And with the late breaker, just to say that WHO stands with everyone in the United States who's feeling the same challenges. We're feeling them here. That's one of the reasons why I cannot be with you in person. And our goal is, and that's why we're here presenting on science and guidelines, is that we must continue to follow the science, put those into new recommendations, and as much look for new ways and new approaches to ensure that we can bring the best to people who need it the most. And I think the long-acting ARV for both prevention and treatment is a place where, we were really looking forward with, great hope that especially the long-acting prevention could really change the environment for reaching the end of AIDS by 2030. And I still think we need to keep that aspiration high, and we need to, as a global community, keep working towards this. Otherwise, we won't be prepared for that sustainability and country ownership that was part of the goal from the beginning of PEPFAR and the beginning of USAID. So today in the next 10, 15 minutes, I think we were dividing it up 15, I'll review what is the role in WHO around developing guidelines and guidance and what we call treatment optimization, and giving you a sense of where we are headed for long-acting ARVs for prevention and also for treatment. You may be aware that we have been looking at the short, medium, long-term perspectives of different and new ARVs, antiretrovirals, coming into the market. And since 2022, we've had long-acting either PrEP and or treatment on our what we call our CADO, or our drug optimization list. So there we had for both our priorities here over on the left-hand side of the slide, long-acting CAB for prevention and lenacapavir, but also looking at where this would fit for treatment, because there's a sense that in the long term, this is a way to actually reach those who are not fully reached and ensure that we can serve the needs when people have difficulty with adherence. So long-acting prevention, we've been a little bit further along on the pathway and guidelines. And our first guideline, if you may not even be aware, that we made a recommendation in 2021 around using the dapivirine ring, which is a ring that's inserted into the vagina with dapivirine medicine, inserted 24 hours before use, kept in a month, exchanged, and having follow-up every 3 months. The effectiveness was 50 to 75%. And I think since in the last 4 years, of course, I don't think we've seen great diffusion of this innovation. And, but it was important to have this as our forebearer for choice for women. And there still may be a role for this as we move out, but more difficult in these scenarios. The next long-acting was the cabotegravir long-acting injectable PrEP, and we made guidelines in 2022. And this was a conditional recommendation, moderate level of evidence. But the idea here was it's part of combination prevention, not to overtake using oral PrEP, but to add to. And in that work, there was quite a bit of work around operational research that was needed to understand the challenges of delivery, looking at safety data in pregnancy and breastfeeding. And I think that piece has been critical to be able to do a much better and faster job around lenacapavir. I think the diffusion of this innovation has been slow as well because of the lack of generic and cheaper CAB-LA. It's an injectable, needs 2 injections every 2, and the follow-up is every 2 months. Efficacy ranging around 80% in relative risk reduction, overall better in women in in women than in MSM and transgender persons. But the adherence and effectiveness was better than using oral PrEP. So there's benefits, we know, and that there's a desire from community to be able to have choices. So now we're in the era of lenacapavir, which is a novel capsid inhibitor, where you're probably very well aware of the studies, the Purpose 1, the Purpose 2, Purpose 1 showing 100% efficacy in cisgender women in South Africa and Uganda, Purpose 2 in a broader set of populations around the world, and trans in men, trans and gender diverse people with a 96% efficacy. And for us, this was well tolerated, exciting, twice a year. And you're probably aware that there were positive results for 12 monthly injections, so going to a year at CROI this year. So again, this felt like it was going to be the innovation that was going to change the trajectory of reaching those who need it most to prevent HIV. So since actually the start of lenacapavir, we've been working on preparing for lenacapavir because we knew it was coming by following the science. So in early 2024, we worked with our pre-qualification department. In November 2024, they put out an expression of interest, and there was guidance given so that bioequivalence studies and what needed to be submitted to WHO and in preparation for generics was already out in the public domain for our manufacturers. We had a guideline group in January, and with all of the partners working on this, there's really been an eagerness to prepare. WHO is participating, has always worked with FDA. Now that's going to be different in the future. But we're also working with the European Medical Association, or Medicines for All, to bring this forward and have pre-qualification as early Q3 2025, and preparing for rollout for innovator in 2025 and 26, and then generics in 2027. So newly, we can't really tell you everything, but we're preparing the terrain by saying we have new guidance on the use of long-acting injectable lenacapavir as an additional prevention choice for people at risk. And the policy brief will be shared at IAS, where the details will be given. I also want to say that we've done an awful lot of work around implementation toolkits, training toolkits, how implementers can use long-acting. So there's a lot of guidance already out there that was developed for CAB-LA that can be transitioned quickly to lenacapavir for community educators, counselors, etc. So we don't need to reinvent the wheel so much for lenacapavir. Now I'm going to switch and speak a little bit about the long-acting ARVs for treatment of HIV. And we've been looking at how we can build a value case. And a lot of that may be about, choice and request and new products that are coming through. But we also need to be thinking about what is the target product profile, what is the access and the cost. And this is the work that we've been doing with other partners. But we really do feel like there's a role for long-acting ARVs. It feels like it's the future. And it may, even though we've had such great important outcomes and viral load suppression with TLD, or tenofovir, lamivudine, dolutegravir, there may be places where this is particularly important. Averting treatment disruptions, reducing transmission during pregnancy, and certainly we know their community would like to see this. This would reduce some of the stigma discrimination, the difficulty in carrying around pills, but we also know there are limitations, not only in value to healthcare workers, it's a different interactions, and then the cost and populations where if we don't have a lot of it in the beginning, where do we use it for the best impact? So we again also have developed a guideline work around this, and we had a meeting actually just a week and a half ago. And we'll just sneak peek is that we're opening up, as it has always been on our CATO list, to looking at new guidance around use of long-acting cabotegravir-rilpivirine as an alternative switching option for adults and adolescents who have had who are on oral ART, but might want to switch for certain circumstances. Again, details of this new guidance will be coming out in July. But just to say, I think we're really moving into a new era. And part of this is important that we continue to watch what's happening in the science. And we know that context is changing, and perhaps even context is going to change again with the lack of potential funding coming in and the security of our ARV supply chain. But we're seeing in the past, we were really working on survival, reducing mortality, late diagnosis, having a hospital-based. But right now, where we are now, if it doesn't slip too far, is we have multi-morbidities, we have pill fatigue and loss to follow-up. We have data that shows our advanced HIV disease. People are often people who started treatment and came out of treatment and are getting back in. We have a lot of self-care, telemedicine, and I think longer and longer people are going to want to be requesting things that fit their lifestyle around the world. And if choices are available in high-income countries, we need to ensure that we don't delay making those choices available for low and middle-income countries for the equity factors. So we also note that this is particularly important for long-acting to do the research in pregnancy and lactation. And I'll just give a shout out to my colleague, Françoise Renaud and Martina Panazzato, who started this working group on pregnancy and breastfeeding therapeutics. And sometimes in the past, we were delaying research of including pregnant women, and this would increase the time for medicines being available for 10, 12 years for pregnant and breastfeeding women. Now we're seeing that because of this work, all of the studies for lenacapavir included or allowed women to become pregnant. And so we have that safety and now efficacy data, I think, moving forward in the population, so we can make those recommendations at the get-go around how to include breastfeeding and lactating women. This will be important for the mother-to-child transmission piece, where we have not been able to end new infections in children fully. So we have a toolkit that I'd just like you to know that is on our WHO website for those doing research, and it has materials on how to study ARVs in pregnant and breastfeeding women. And I know that ANRS and your colleagues in the audience have probably used this in the past, and they're now helping us bring this to even other areas, hepatitis, STIs. We also want to make sure that we are always thinking about the safety pathway, following up on rare events, doing implementation studies, but we don't want that to inhibit the ability to bring the new innovation to patients and to clients as soon as possible. So I'll end on what are our perspectives on what's coming next and how we are going to be thinking about introduction and access. And I know our Unitaid colleagues will speak about that in greater detail. We continue to look at our CATO and PATO lists, and this year we're going to update that. And we'll be looking at clinical and programmatic benefits. And we'll be looking at equity, cost effectiveness, and challenges to implementation, because now we're going to have to be looking at what are the service delivery options. If a lot of the clinics have closed, will this be something that will be handled in pharmacies, handled in hospitals? How do we ensure that those who need it get it? If we look back at our CATO, PATO, and even drug resistance, we brought prevention, treatment together, and drug resistance to this optimization platform. I think we're getting to a point where we've fulfilled what we had planned from way back in 2010. But as we're moving forward, our longer term goals here on the right will be around looking at other drug combinations for long-acting treatment. We're not certain that CAB or pivarine is the best regimen, so we would like to see other regimens. Some studies we hope will continue will be CAB and lenacapavir together for treatment, and looking for longer durations, self-administrations, implants, etc. as we move forward. And certainly for children, the postnatal prophylaxis period is another place where injectable BNAbs or other medicines that can be taken to infants would be a very good place to avoid infant infections. In 2021, we put out a product characteristics, sort of like a precursor to a target product profile. And we wanted something to be equivalent to TLD because there was such good success there. We looked at tolerability, resistance, having low barrier, durability, making sure you can miss some doses, convenience, programmatic delivery, and special populations. Ideally, we'd like to get to a cost in the range of TLD, but that is a high barrier. Cost is $37 a year. Can we get there with long-acting? So what we're doing now is we're looking towards an improved long-acting target product profile. It was started in 2024. We'll finish it very soon. But we've expanded the areas that we're looking at. I think you can look at these slides later. And we would love to have feedback. Because we know that what we have right now for treatment, we have to have something that can be used in the case of an NRTI drug resistance. And we also know that there is a pipeline and that we need to be able to bring that pipeline and studies into the work in a regular basis. And this is what the pipeline looked like, that we have all the different products that are on the different approaches, but where they are in phase 3, we're going to have to be ready to be able to bring those new products in should they prove to be successful for treatment, as well as the length and durability of these tools. I know there's a lot of excitement around BNABs, but for low and middle income countries, we're going to have to overcome the infusion requirement, etc. So we're hoping that in the future there will be easier approaches and those that last at least a year, which seems to be a great innovation in HIV research. So let me end by saying we're bringing together our target product profile in something that Chai has been working on as a target regimen profile, and all of this, I think, will help us to be able to give good signals for those doing research, for those who are innovators, and of where we need to be going in the next 5 to 10 years for long-acting approaches. And just summary, we're doing both. We're excited about both long-acting prevention, long-acting treatment. Sometimes we've been told that WHO is not interested in a long-acting treatment, but we want to see a regimen that is really durable and is easy to use, and also that fits the bill of being resistant to possible HIV drug resistance, but also that will be durable for the long term with the investments that are going to be made globally to make these a reality. So thank you very much. I want to thank Françoise Renaud and the team here at WHO for help making these slides. And certainly we have them in French as well, if you would prefer to read them in French. So this I'll pass back and stop sharing. Thank you very much.